So I'm going to do a little bit about maintenance therapy after transplant. I have nothing to disclose, but my objectives are going to be to review the current recommendations for maintenance therapy in multiple myeloma, lymphoma, and leukemia. I'm going to identify some of the desired population and chemotherapy agents that we use for maintenance therapy, and then last, discuss the controversies that we usually face as pharmacists and some of the complications surrounding maintenance therapy in general. For a little background, and I know this is pretty much basic, but we all know that transplantation offers cures or durable remissions for many malignancies. We still have to deal with relapse that occurs frequently in many diseases, and this highlights the need for why patients that have high risk need some type of preventative measure to prevent relapse. Prevention is usually the most feasible and the most effective way to try to manage this. And ultimately is the best way to protect the patient. And I think this is best described in more of a picture form. One of the strategies for relapse prevention I think is best depicted here, and it's broken down into 3 different areas. So the bottom is your patient in complete remission, and then you can see this patient has some type of MRD or minimal residual disease we can monitor, and then at the top you can see active disease. And if we start a patient on maintenance therapy, when they're in complete CR, you're actually really just suppressing the disease or no disease at all. Once you start seeing patients with MRD or active disease, it's really hard to kind of get back down to the complete remission area, which sometimes it's near impossible after transplant. Other strategies for relapse prevention kind of is broken down even before we start the transplant. So it's one, using new drugs that possibly come out into regimens for conditioning, or new regimens that potentially that wasn't used before has now good data. Looking at your graft, using T-specific lymphocytes, or doing a graft that's depleted of T cells. If you have a disease that it's something that we can monitor, like MRD, using that as a parameter, or using that as an intervention if you do have a positive result. If they do relapse, if they're on still immunosuppression, we can take that off to kind of invoke a graft versus host response. And then lastly, before going into transplant, we define what their relapse risk is, and if there's maintenance, able to use that after transplant. Some other preventative benefits is that you can improve your disease control before the transplant, along with maintaining it as they continue and the graft matures. The other thing is you can detect and preemptively impede relapse from recurring. And then if you're doing an allogenic, you can potentially increase your graft versus tumor potency by using prevention. The disadvantage is, and this is always a big thing, is you're going to give them an agent that is potentially toxic when they don't have any evidence of relapse. And along with this, it comes with many side effects and many drug interactions that causes significant management issues. So the 3 groups I'm going to talk about today is multiple myeloma, Hodgkin's, and then leukemia. And with the first group, with the multiple myeloma, I'm just going to focus on the IMiDs and then the proteasome inhibitors. For multiple myeloma, we know that autologous transplant is really beneficial when a patient has achieved a complete remission or a very good partial response following induction therapy. The whole goal is to get some person that has multiple myeloma either to maintain a maximal response to obtain a really long-term survival. With a transplant, you can improve their progression-free survival without maintenance by 2 to 3 years. And for maintenance therapy for these patients, it's actually not really well defined. Most people will say any person with any stage is really eligible for maintenance therapy if they have chromosome or abnormalities or not. We do know that maintenance is really not going to overcome your prognostic score of if you have a bad cytogenetic profile, but it does help with progression-free survival at the end. So we recommend that all patients usually get some type of maintenance after transplant with multiple myeloma. So prior to what we use now of lenalidomide, the 2 agents that were approved for first was interferon alpha and thalidomide. So with interferon alpha, I feel like it's making a comeback because a lot of people were talking about it this last couple days. We used it 3 times a week. You only got about 4 to 6 months in progression-free progression-free survival, and overall only a 7-month benefit in overall survival. But we all know about the toxicities, and it's also very cost prohibitive. Then it was moved over to thalidomide, which improved progression-free survival, but actually had no improvement in overall survival. And ultimately, a lot of patients couldn't tolerate this drug either due to peripheral neuropathy, and almost a quarter of patients had to discontinue therapy due to that. As of 2017, the NCCN guidelines have actually removed both agents from maintenance therapy recommendations, so this is kind of like in the past, probably not going to make a recurrence anytime soon. What we do use is lenalidomide, or I'm just going to call it len from this point forward, and anything in transplant, I'm talking about studies from 2013, 2014. I know that's a couple years back, and this is supposed to be an update, but in transplant, an update is usually 5 to 10 years, because we're a little bit slow in the updating process, not like a solid organ. So we still use these. These were phase 3 studies that were placebo-controlled with a large amount of patients that used low-dose lenalidomide. And overall, you could see it doubled your progression-free survival. It didn't affect any overall survival, which is kind of like the mainstay with multiple myeloma, but it did give patients longer disease control. The other thing we noticed with it is that it increased secondary primary cancers, and then instead of peripheral neuropathy, you got more neutropenia with this group. Now, for the nuts and bolts of what I like, as much as I love studies, this is what I really need to know for my day-to-day knowledge base, is that usually when we think of lenalidomide, we think 25 milligrams for induction. But with maintenance, that's just too high, and most patients can't tolerate that high of a dose. So they started off with 10 and then increased it to 15 at 3 months if they can tolerate it. But most patients couldn't even tolerate the 10, and about a quarter needed a dose reduction. So I don't even know if 10 is a good starting dose. Usually what I do is I look back at the patient and see what they were on prior in their induction phase and see what they could tolerate, and then kind of use that as my gauge of where I should start them with the lenalidomide. When they did start them, it was between 90 days to 180, but you don't have to rush it. Usually they say when you have hematological recovery from your transplant, you should start it. But they looked at patients that started earlier versus later, and there was no difference. So if your patient's not ready to start it, you don't have to rush about starting lenalidomide maintenance. The duration of the study, I put unknown because there's a 2-year stop time that they put on this. It wasn't due to the disease progression-free survival or overall survival. It was actually due to the secondary primary cancers that they saw. So they have a recommendation that you do 2 years, but they've noticed also if you went past the 2 years, you actually still got an additional benefit with progression-free survival. So usually what we do is once we hit the 2-year mark, if a patient is still doing well and could benefit from more maintenance, and they haven't seen a secondary primary cancer, then we actually will continue on and then just keep monitoring them for this side effect. What they did see was there's some hematological, there was also some solid organ, and then there was some non-melanoma cases included in that group. For bortezomib, I picked out 2 studies. There's a couple more. Bortezomib is a little bit different with maintenance because there's not a set schedule like lenalidomide. What I have here is 2 different ones to kind of show there's many options for doing maintenance. They did it every 2 weeks. The one below did it weekly. There's one out there that does it monthly. There's another one that does it every 3 months. So there's not a good answer of what bortezomib maintenance should be. And the duration also is kind of iffy too. This one was continue for 2 years. There's a 5 months. So there's not a good recommendation right now of how long you should give bortezomib or what the scheduling could be. As you can see, the progression-free survival is not as robust as what you see with len, which could be due to the schedule. It's quite unknown. But you did see a good adverse effect profile. You didn't see any neutropenic issues, along with you didn't see as much peripheral neuropathy as you typically do when using it for induction phases. I included this because not just knowing the drug, it's also the cost, because this is a huge thing about my patients is that, yes, we know you need to go on maintenance, but if I can't get you the drug, it's just pointless for me even to be sitting here and talking about it. There's not a lot of cost analysis, but when I came across this, I kind of want to include it because I know this is one of the issues I come with, that many of these maintenance therapies have high copays. And then, yes, there's great assistance programs, but what do you do if you don't have the eligibility for an assistance program? So in the past, what we've done is you could potentially use bortezomib for your maintenance, and as you can see, it's much cost-effective compared to lenalidomide, along with also when they factored in adverse effects and also secondary primary malignancies. So it's an option that potentially could benefit a patient, knowing that you could get about the same for progression-free survival and also help out with them being able to afford their maintenance therapy. For future directions, I kind of added pomalidomide because that hasn't really figured out what the niche is going to be. What we do know is it's probably going to come down the pipeline as maintenance therapy. I don't quite know what you would do with a patient that comes in prior to transplant on POM. It's kind of ridiculous to go back to a len maintenance if they've already failed it. So we've actually continued people on a low-dose pomalidomide for their maintenance therapy instead. And then also with the new oral proteasome inhibitor coming out, this might change the game of doing this as your maintenance therapy or potentially doing a combo as maintenance therapy. So this is, I think, new things that are coming down the pipeline. The next group we're going to talk about is Hodgkin's lymphoma and brentuximab. There is a talk tomorrow about Hodgkin's lymphoma, and they're going to go through more of the Athena trial in more detail, but I wanted to highlight what, as a pharmacist after transplant, do we really care about. For lymphoma with Hodgkin's that is either primary refractory or relapse, once we do a transplant, we can cure about 50% more patients. So it's 50% we're still not capturing. With this, we were trying to figure out what risk factors would be associated with poor prognosis. So this is still a little bit in the gray area because some people use different standards of what the risk factors are. This is the NCCN guidelines, which they use are one of the following: primary refractory, initial remission duration is less than a year, if you have any presence of extranodal or advanced stage disease, and then the optional one is either the lack of chemosensitivity or residual disease at the time of transplant. With the Athena trial, they did a year of brentuximab maintenance, and this is both the updated version in 2016. So they did the 2-year progression-free survival was 65, and then when they looked at 3 years, it was 61. For overall survival at the 2-year mark, they didn't see any difference, but this is highly debated because almost 85% of patients in the placebo ended getting brentuximab at some point after transplant, so a little bit confounding picture, along with a lot of patients in the placebo group actually went on and got an allo. So it's very hard to phase out if there is an overall survival benefit. There probably is, we're just not going to be able to find it with this data. And then the other thing they looked at is in the post hoc analysis, they grouped patients by risk factors. And they listed the risk factors here, which is a little bit different than what they originally classified in the study. But ultimately, they showed that the more risk factors you had, actually the more of a benefit you would get either in progression-free and overall survival. So it's good to know how many patients' risk factors they have, because that can beneficially weigh you to doing maintenance or not. So this is what I'm most important about is what do we want to take home as a pharmacist. So first, we don't really have the best definition of high risk. We have many different versions with many different kind of components. So it'd be nice to have what is the standard for a high-risk patient and then how we can implement of how many risk factors would equal needing maintenance therapy. For the starting dose, what they used was treatment doses. So it's 1.8 mg per kg every 21 days for a year. So if you have a patient that's already in CR, it's kind of a little confusing that you would want to give them another year of therapy and treatment doses therapy. So the question is it really needed to be at treatment doses? Could it be at a lesser dose? Is it the interval that's really needed? Could you spread out the interval? These are all questions that I think are still unanswered and could potentially signing up your patients for a whole nother year of treatment that maybe is not needed. They started it between day 30 and day 45, and the duration of the study was a year. But with the patients that had adverse effects, that had to discontinue, actually lost some of the progression-free survival benefit. But if you had an adverse effect and actually just dose reduce and were able to complete the year, you still kept it. So it kind of still goes back to what I was saying about the dose. Maybe it's not the dose that's needing, it's the interval that's more important. So you potentially could space it out a little bit more and still get the benefit. And we've actually done this with a couple patients. We've done really stuck with it for 6 months and then kind of moved it out to not every 21 days, but every month, and then maybe every 2 months, and they did just fine. So it's still a lot of questions, but I think there's a lot of questions that need to be answered. For adverse effects, there was no secondary malignant disease, and then the thing that they noticed was peripheral neuropathy. Ultimately, about 88% of patients actually developed it. Even while on therapy, 23% improved, and by a year after stopping therapy, almost 65% completely resolved. So as long as they can keep on it, I would say stick with it because it's not a permanent side effect, and mostly all the patients, or predominantly most of them, got resolution in the end. So this comes to my first and only ARS question, and I'm not good with ARS questions. They always break down on me. It's just like, I don't know why. I think it's me, but maybe it's my lack of media. But JT is a 46-year-old male with relapsed Hodgkin's lymphoma, stage 2B. He's treated with ABVD times 4 cycles with a PET scan after the second, showing a very good response. But after the 4th cycle, it showed increase in metabolic uptake in the mediastinal lymph node. Therapy was changed to ICE for 2 cycles with a repeat PET scan showing unchanged mediastinal lymph nodes, and then the lymph node was irradiated and the patient went on to receive an auto transplant conditioned by B. So based on the patient, what is the most appropriate course after transplant? We do brentuximab for a year, brentuximab for 2 years, no maintenance is needed, or maintenance is only needed if the patient had extranodal disease prior to transplant. And then the last group we're going to talk about is leukemia. So I wanted to focus on FLT3 and Philadelphia positive because that's more of the mutations that we kind of see with our patient population that will require maintenance therapy. For FLT3, it's showed in about 25% of patients with AML will harbor this mutation. It doesn't really change your remission rates if your patient is mutated or not, but really it affects what the relapse rate is going to be. So FLT3 mutated positive actually has a higher relapse rate. You're only seeing about 30% are alive at 5 years, and even if you transplant them, you're only capturing about 20% more. So it's still a high-risk disease that we need to target. The other group would be the Philadelphia positive group. It's a mutation that we all know is found in CML, but it's also noticed in ALL in about a quarter of patients and in some AML patients. I'm not really going to talk about CML because we really don't transplant that many patients in CML anymore. And that's, I think, another topic altogether of what you would use for maintenance if you did. But I really wanted to focus more on ALL and AML in this time because I feel like that's more of the patients I see. We do know that with imatinib, it has improved CML progression and also has improved your ALL and your AML overall survival with the addition of a TKI. And with this disease, we definitely utilize the MRD as your monitoring parameters for your predictive value for relapse. So for sorafenib, the data that's out there is really phase 1 or prospective data that's available. The first one, Chen, is actually a continuation into Bruner, and it was showing that about one year overall survival is between 95 and then down to 2 years it goes to about 80%. And then you see about the same with your progression-free survival. With Pratt's, they really looked at overall follow-up, and then they saw that patients at 450 days, really about 50% had no relapse. With this also, the patients had a lot of dose interruptions and a lot of discontinuation of therapy. So it's hard to say if these overall survival and the progression-free survival is that accurate just because it was really hard to keep the patient on therapy. And this actually is still something that I deal with every single day. It's a range that we use of 200 to 400. I never start anyone off at 400. It usually goes, either they get diarrhea or they just can't tolerate it. So I usually start at the 200 twice a day and then gradually move them up to 400. And sometimes I can't get them up to 400. So really it's based on what your patient's going to respond to. The range they started was from 30 to 180, but they usually said per physician's discretion, which usually meant hematological recovery. Either that or having no other active issues that are going on. For duration of therapy, most of the studies were done between 1 year to 2 years, but really if you're going to relapse with FLT3 positive, you usually do it during the first 2 years. So some physicians say if you haven't relapsed after 2 years and everything is going fine, you potentially could pull back on the sorafenib if your patient is deemed okay with it. Otherwise, it's hard to say how long to really continue sorafenib with these patients. For drug interactions, this is actually a little bit of a red herring because, yes, it's a 3A4 substrate, and potentially you would have the same interactions with your azoles, but actually it's the inactive form that goes through the 3A4, so you really don't need to do any dose adjustments with azoles or anything else that has a 3A4 inhibition attached to it. And then lastly is the adverse effects is very similar to what you might see with complications from transplant. So you see rash, diarrhea, elevated LFTs. So you really have to tease out, is this drug or is this maybe graft versus host? That's why I usually say start low, monitor them, watch how they're doing, and then increase it. So if it is diarrhea, you can kind of phase it out. It's more drug related than graft versus host related. And then with Philadelphia positive chromosome, for your ALL and AML data, there's very few articles out there. The majority is going to be in imatinib, but I don't think I've used imatinib for a TKI in a very long time. There's some case reports with dasatinib and nilotinib, but really nothing out there for ponatinib or bosutinib. Once again, you can see the dose reduction is actually lower than what you would do normally in an induction phase. And then also the diarrhea and other side effects that you see with TKIs is still present in these patients that take these TKIs, and you see they're a little more amplified than usual. So with this, we kind of say the same thing. We don't use the same dose as induction. I still titrate these patients up with your TKIs. I usually always use what they were on prior to transplant as my maintenance therapy. So I know there's a whole bunch of data for imatinib, but if they were on dasatinib, I'm going to continue on dasatinib after. The median range is also 30 to 200 in most studies, but the median was about 60, which usually is about the time when most patients have completely hematologically fixed themselves, and if they don't have any active graft versus host or any other issues, would be a good time to start it. With this disease, you can definitely monitor for MRD, and if potentially detect it early, or just continuing using it as your monitoring parameter. For duration of therapy, overall survival is usually looked at as 5 years here, so you potentially could continue this for 5 years and then discontinue the drug. For drug interactions, we all know TKIs have a boatload, 3A4, proton pump inhibitors, so you always have to watch out for that. And then once again, you still see the same kind of confounding adverse effects that you see with sorafenib. So fluid retention, diarrhea, cardiac. That could be from this drug, it could be from the conditioning regimen, it could be from a long-term complication from transplant. So it's very hard to kind of figure out if this is also drug-related versus disease-related. And then to kind of bring it all together, just for a summary, there are many strategies for prevention of relapse disease, and maintenance therapy ultimately needs to be part of that process. Identifying your high-risk patients in multiple myeloma and Hodgkin's lymphoma are really beneficial for this. Also looking at your chromosome abnormalities, determine if you have any agents that potentially could target this for maintenance so you can suppress relapse. And then if you are going to use relapse therapy, determining the appropriate dose, looking back at their prior history to see how they tolerated it prior to transplant, and then also looking how the patient is currently doing and if they're able to tolerate starting an additional chemotherapy agent. Always look for drug interactions, and then kind of monitor for your adverse effects and understand that you might have to phase out if this is drug-related versus your disease state, and then ultimately trying to figure out what's the best duration of therapy, because you don't want these patients to be on long-term oral chemotherapy agents if they don't need to be. So duration is also very important. With that, does anyone have any questions? I'll turn it over to Karen. Okay.